This is probably a bit of a futuristic talk for you, because this is really in its infancy, trying to figure out what role complement plays. I spend every single day of my life working with complement-mediated kidney diseases, so this is an area that I feel pretty passionate about, complement and its role in disease. This is my disclaimers, or I actually do some consulting for Achillean Pharmaceuticals for a disease called C3 glomerulopathy. It really doesn't have any affiliation to this particular discussion, except for one of my slides, which I am, by the way, happy to share with anyone, but one of my slides will talk about drugs that are not out to patients yet. They're still in the beginning phase, so, and they do have one of those drugs. So what is the role of complement in health first? We have to start there. And what I'd like to say, and many of you will probably know this, but it's part of your innate immunity. It's part of your defense against invading organisms, against cells that are dying, et cetera. And so it's an incredibly important part, housekeeping, surveillance. If you puncture your skin with a thorn and you introduce bacteria into your body, complement is activated. Complement system is responsible for removing those invading organisms, and it does it by a number of different ways. And we're going to get into a little bit of the detail, but because this is a diverse audience, I'm not going to sort of zero down into this too tightly, except for to share with you the pieces of this that you can clinically look at. We opsonize both dead cells, we opsonize, or we have chemotaxis involved with whenever complement is activated. So there's a number of the very basic functions that complement plays for us. Importantly, it's very rapid and very effective. This is unlike your humoral immunity. It is something that you're born with. So you're born with your complement proteins, unless, of course, you're genetically deficient, but you're born with your complement proteins, and they are active at all times in your body. So you're really afforded the opportunity, either by things that are floating around in your bloodstream or in your tissue fluid, or that are actually cell-bound, that are ready to activate at any moment should you require your immune system to be activated. Often it's by pattern recognition, so you'll hear about the lectin pathway and the fact that it recognizes certain glycosaminoglycans on a microorganism. That's how it's activated. But also, complement proteins will activate receptors that then turn on a whole host of things that happen within any given cell. And so, again, you're going to see that complement will play sort of a multiple role in a lot of the things that, a lot of the diseases that where it's really black and white where complement plays a role. And then next, amplification is possible. I mentioned to you that it's part of your innate immune system. It's always present. It is always present at a low level unless you need it. Then if you need it, it can be amplified by thousands of times to more proteins will be made, more activated proteins will be made. Importantly for disease, particularly for the kidney, I'll say, the complement system is not cell-specific, meaning it can opsonize not only a self cell or a bacterium. Either one of those is absolutely possible. What's really key is that in general, the host has some sort of cell defense. And for instance, those of you who know atypical HUS, one of the major cell defense mechanisms is a protein called factor H. That is important for the host to protect themselves from an activated complement system. So at the end of the day, the host's ability to regulate complement is absolutely critical for keeping homeostasis, keeping away from disease, if you will. So here's, you saw the coagulation pathway this morning. I have to share the complement pathway with you. And the reason I'm going to do this is because I want to share with you, again, I mentioned already that clinically I can tell you where in this pathway we can monitor and where it may be affected in the nephrotic syndrome. So let's just start, well, let me start over here. This is the lectin pathway. Classical pathway, alternate pathway. There are three different pathways that complement can be activated through. This one is actually one of those that's activated by the lectin proteins recognizing some specific glycosaminoglycan on top of a cell. So that's how that one would be activated. You might recognize those as a symbol for antibodies. The classical pathway is going to be activated by antibodies opsonizing a pathogen, for instance. And then the alternate pathway is one that actually is what we call low level or active at all times, but once it enters into a cycle, can be amplified tremendously. So let's just start from the top. C3 breaks down into C3A, which is an anaphylotoxin, and C3b. C3b enters this amplification loop. If it binds a fragment of B, which is BB, releasing BA, and joins another C3b, then what happens is this can then cleave C3. This was a spontaneous cleavage here, spontaneous hydrolysis. Once it enters this pathway, now this entity can keep cleaving C3. This can go on and on and on. Then we can go down into add another C3b. You'll cleave C5, C5a falls off. Again, another potent anaphylotoxin, and we'll talk a little bit more about what that means to the kidney, or to the body anyway. And then C5b is the first component of this guy. We often will call it the terminal complement complex. You may know it as MAC, membrane attack complex, also called C5b through 9. And again, the reason this sort of understanding not only what the breakdown products are, but what the active proteins are, because we now have the ability to actually monitor these in the laboratory and in a clinical specimen that you can draw from your patient. Now, I should have perhaps started by saying, or maybe I did a little bit by saying complement. Where's complement in the nephrotic syndrome? There are a class of diseases where there's clearly complement involved, and we've had an opportunity to figure out how best to measure these and actually what they may mean to the patient's pathology. Now we need to take the next step and see if there are situations with the nephrotic syndrome that they may also be involved. So, unfortunately, it is a pathway that you'll perhaps have to maybe understand in the future. I don't know. We'll have to sort of wait for the science to catch up with this, perhaps. Let me just mention very quickly that the anaphylotoxins, and we have a couple, we have C3A and C5A, their job is to call cells to a site where complement has been activated. Now, if you are a hematologist or have done much by way of hematology, you know those are neutrophils. I've listed neutrophils there, but they could also be mononuclear cells of some kind. But nonetheless, they've been called to a site of energy, a site of injury where in fact complement has been activated. So you not only have this self-immune response, but then you have this thing called the terminal complement complex that will actually be the end result of activating a complement pathway. And we might find out that that's important in some of our diseases. So, role of complement in disease. Well, how about the dark side of complement activity? That's really what we're talking about. We're talking about normal activity. We're talking about the same activity that you would be talking about in innate immunity in an effective program of immune surveillance. Now we have to talk about how it might be a problem for the patient. These are very generic. So you can, of course, have a complement deficiency. You might be missing a C2 or you might be missing C4. The nephrologist in the room might know that as a patient who might have lupus. That can be congenital, of course. In the case of atypical HUS, that can be acquired. For instance, patients can make an autoantibody to factor H, and that can be your acquired problem with complement deficiency. It's sort of indirect in that you cause complement consumption in that position. Or you can have excessive activation of complement, and medical people will know this as you know, a patient who is septic has excessive complement activation. So you have lots of complement breakdown products, lots of active complement pieces that then are actually, if they're working as an anaphylotoxin or whether they're actually helping create the terminal complement complex, you have that activity going on much greater when you have a septic patient. There are biomaterials that activate complement, and it can activate it excessively at the site that can then, go systemically. Biomaterials are a little less complement activating than they used to be, but we still classify that as an option for how you might get excessive complement activation. And then, of course, there are ways to have normal proteins that don't act normally, and I'm speaking particularly there of thinking about genetic abnormalities, but that's another way that you might have excessive activation. And then, of course, insufficient regulation, which you can get back to a factor H, for instance, I'll use as an example. If you're not adequately controlling the alternate complement pathway, then in fact, you may have excessive activation of the pathway. Bottom line, as I just mentioned on the last slide, the real key here is a balance between what's active, what you need to be active, and then can you shut it off, or is it being adequately shut off for any given disease? So, what is it about complement activity that is a problem for the kidney? And this is a generic discussion or a generic question. And it turns out that whenever complement is activated, you do trigger inflammation. And if I just use the very basic definition of inflammation, it's whenever cells or protein mediators of the defense or the innate immunity are called to a particular site, then you have an inflammatory process. You have increased cells there, you have increased edema, you have increased release of cytokines or other proteins that may be important to that inflammatory process. So turns out that inflammation is very important to the kidney. We know that less in nephrotic syndrome, more in the nephritic diseases, IgA, ANCA, etc. Those are highly inflammatory processes that can be very damaging to the kidney. Those often can result from complement activation. There's lots of other ways too. I don't mean to make it sound like complement's the only thing. And again, a piece of that inflammation is this chemotactic effect of complement, for instance, the anaphylotoxins, the C5a. And then finally, the kidney is particularly susceptible to this thing we call the membrane attack complex, or the C5b through 9. And I'm bringing these three up because I'm going to show you some examples of how that may apply to the nephrotic syndrome or the primary nephrotic syndromes. I'll really only talk about minimal change, membranous, and FSGS. There are definitely primary glomerular diseases where complement plays a key role. And in fact, it's probably the primary pathology involved. And I already mentioned them, C3 glomerulopathy, for instance, atypical HUS, for instance. Very likely, abnormal complement activity plays a role in lupus, probably not the primary problem, but nonetheless, there are primary glomerular diseases where complement's key. Here's the problem when you ask the question, what is the role of complement in nephrotic syndrome? The research is really too early on for us to really know what the answer to. So that's why I mentioned that this may be a little bit of a futuristic talk for you, but I want to sort of give you a framework for how to think about it moving forward, because people are doing research in this area right now. So I'm just going to very briefly give you an idea of what we can test clinically and what might help you figure out how complement is involved in the nephrotic syndrome. And first, I'm just going to show you, so when you activate complement, we already talked, and I know that's very tiny, but this is the same figure that, that you saw a few moments ago. You're activating complement through one of those three pathways. But then once you activate complement, then you get complement activation fragments, just as you can imagine. And in fact, if you remember, you had C3 there, you had B there, you had C5. If you get activation, then you get these products which are now active. And I'm saying that again and again, but the point is that if I told you that your patient has an elevated C3C or an elevated BB, this is a representation of active complement, not just that complement has been broken down and is floating around waiting to be excreted by the body. These are the active proteins involved in complement, and this becomes a little bit important when I skip forward here in a few minutes and talk to you about membranous nephropathy. And again, mentioned to you the C5b through 9, very important terminal complement pathway activity. Then, if you have active fragments available, they can not only act to be parts of an important enzyme, but you can also have tagging of, it could be cells, like senescent cells, cellular material that the body is trying to get rid of. You can tag those. But of course, you can tag bacteria. Each of these ends up being ways to actually opsonize or tag a cell for some effect. For instance, C5b through 9, I didn't mention before, but you may recall from some of your immunology, even in medical school or in undergrad, C5b through 9 is responsible for actually puncturing holes It makes a channel, pokes holes in a bacterium, then there's this efflux of calcium, and then the bacterium is destroyed. The concept is very similar if it attacks self. If you poke a hole in self, then you do damage the normal function of the cell, and it can happen particularly, I'm going to show you how, or give you some evidence that it does happen in podocytes. And then finally, if you have not only active pieces of the complement system, but then you have breakdown products or opsonization proteins, then you can also get deposition of complement proteins onto important tissues. And for the purposes of our discussion, that could be the podocyte, or it could just be the kidney biopsy. So you have the deposition of complement in the mesangium, et cetera. And if you get deposition of complement, what is not clear yet in many of our diseases, but particularly in nephrotic syndrome, is whether is the complement deposition actually playing a role in the pathology of the disease, or is it a secondary issue? Is it just being deposited because complement has been activated somewhere? And then, of course, importantly, for a laboratory would be is that can you measure either the activation products or the opsonization products, or even can you identify by microscopy the deposition products? Because if you want to do a study in any given disease, whether it's nephrotic syndrome, then you need to be able to have some sort of measure of what's going on, to be able to compare it to whatever the clinical outcome is, or with response to therapy, et cetera. So we want to know whether each one of these, if we could find them either in your bloodstream or sitting down on your kidney, whether it represents disease activity or not. And so also very important. So let me just recap that again. So complement can be activated by 3 different pathways. Ultimately, it's the alternate pathway that ends up being the amplification loop for the other 2 pathways. And the reason that's important, you'll find that often what's available to you clinically are going to be alternate pathway markers or alternate pathway biopsy findings, et cetera. And it's primarily for that reason. Because there is amplification through, because the AP is the amplification loop, it's most often those byproducts or those breakdown products that can be detected. If you get activation, you get the active moieties, and again, this is memorization for you if you really want to know them. It's not something that you're going to be able to sort of intuitively figure it out, except to say that C3 is going to break down into C3A and C3B. It turns out C3B is the active form, but we can find those in your bloodstream or sitting on your kidney. If you have opsonization, then you have your key component of the beginning of your innate immune system. If you can opsonize things, then you can, in fact, begin to do your housekeeping chores, if you will, with respect to your innate immunity. And then, of course, deposition. And again, just to recap, are we really depositing because we're actually causing disease, or are we depositing just because it's the kidney filters just so much blood that we're just catching things as they're floating through? So, childhood nephrotic syndrome, and actually I could have easily put in there primary nephrotic syndrome. That's really what I mean. There's just a few points that I should make, in that there's very little data that complement plays a role in minimal change disease. And I'm going to show some very, I'll call it wimpy pieces of evidence that it might play a role, but nothing that you can hang your hat on, nothing that would make you want to move towards thinking about an anti-complement approach. There's going to be some talk this afternoon, I think, about additional therapies that may be available for patients with nephrotic syndrome. Right now, anti-complement therapy is not going to be anywhere close to your minimal change patient, as far as I am concerned. There is both animal and human data that the complement system may be playing a role in actual pathology of membranous disease, but still very early on before we can actually substantiate whether that means that that's a good treatment target for you. And then finally, there's very limited human data, not so much animal data on FSGS, whether complement can be playing a role. So let me start with minimal change disease, and recognize this. this is an old report. What is it, 1987? I mean, this obviously is a very unusual circumstance and not a reason for you to think that actually complement is playing a role in minimal change, except for the fact in this one patient. That's not enough for you to have the evidence that complement may be playing a role in minimal change. So how about this one then? This is actually 1998 also, where they did multiple biomarkers, let me just say it that way, and what they discovered that the serum C3 levels were actually quite high in minimal change. And if I hadn't put that very next statement, would you all have guessed that? In fact, I think many of us may know that C3 is almost like a SED rate or almost like a CRP. C3 is an acute phase reactant, so that is, in my mind, just an association with minimal change in this setting. These often, I shouldn't say many times, often these children do actually have an intercurrent infection, whether it's viral or bacterial, and that may in fact be why they were noticing that the C3 was elevated. This doesn't mean that the complement system is involved with minimal change, other than it may have been an activated innate immune system going on right here. And then the other piece of that particular bit of information is that factor I and factor B levels appeared to be very reduced. Do you know why? Exactly. Turns out that it's not unlike some of your immune globulins that end up in your urine, but it's interesting, and I don't expect you to know this, but essentially these two should cancel each other out. Factor B is a proactive, complement protein. Factor I is a brake for the complement protein. So the fact that you're using both of these, if in fact it's equally, then that might be another reason why you could say that complement is not playing a role in minimal change. This is all I got for you on minimal change. Even with a really good literature search, I couldn't find anything much else. Now, part of it's because people aren't looking, but it's also because right now, at least, there doesn't seem to be a clear path to that. So what about membranous nephropathies? There's a little bit more with that because there's a decent mouse model. It's not perfect, but you guys know what that is? It's a podocyte. So because it's going to be important to sort of talk about that podocyte, because that may actually be where the problem with complement is if the research pans out over the coming years about what role complement might play in membranous. So I'm going to take the opportunity to take a step back. I think you're going to get a little bit more of this discussion later, but hands down, we think we understand what the primary cause of membranous nephropathy is, or at least, we know that in 70% of patients that, I might be losing my, 70% of patients with primary membranous nephropathy do have this association. Probably this is very likely to be pathology. So I'm not at all trying to insinuate that complement is primary in this disease at all. I'm just sharing with you as you move forward in thinking about treatments for patients with, whether it's membranous or FSGS, we're often looking for ways to make things better. I mean, we use ACE inhibitors in this group of patients. That's not going towards direct pathology, right? That's actually helping patients with some of the manifestations of disease. So having said that, now let me move forward to why complement might be involved. So observations from animal models, and again, this is the animal model for membranous. It turns out that you can get those immune complexes with that the antigen and the antibody, that I just mentioned to you. That's maybe accounting for 70% of patients. You can get deposition of these complexes underneath the podocytes. Okay, so subepithelial deposits. When you get deposition, you get complement activation. Now, there are some problems with this because most of those antibodies are IgG4 antibodies. They're not supposed to be complement activating, et cetera, et cetera. But in this mouse model, you activate complement. You insert MAC because if you remember the pathway, you get all the way down after you've activated complement. You get to MAC, that guy at the very bottom. Because complement's been activated, you do insert MAC into the cell membrane. Because it's a nucleated cell, not like a bacteria, it gets what we call a sublethal injury. And in fact, the cell doesn't die, it just changes a lot. And in fact, Lots of pathways are activated because you now have an activated cell. You now have MAC that's changing the calcium content inside the cell, outside the cell. But then you also have cytoskeletal changes for that podocyte. So at the end of the day, you get these foot pros abnormalities, which we do see, of course. You get loss of, this is animal model data. You get loss of the slit diaphragms, and then you get cell matrix changes. But the point is that you end up with proteinuria. And you end up with proteinuria in part because there has been some complement activity at the level of the podocyte. So what is the evidence in humans that this actually might be playing, that complement might actually be playing a role? Well, it's not very much at all, unfortunately. There are coming every day a little bit more on this, but we've known that C3 deposited on the biopsy of membranous patients for many, many years. Again, whether that is a byproduct of the innate immune system being made active, or it's a byproduct of complement being broken down, or whether it's actually playing a role in disease, we really don't know with respect to the C3. In other diseases, by the way, we do know that C3 deposition there does relate to disease, but we don't in membranous. So patients with, and it turned out that, and I think the reference was on the other slide, but it turned out that the patients who actually, the more C3 that was deposited, the heavier the proteinuria was in that group of patients. So there appeared to be at least an association between complement, not so much the C3 deposition, whether that protein itself was the disease maker, but there appeared to be an association between C3 and the deposition of protein. And then it's not at all uncommon that you will see C3 co-localized or co-stained, if you will, on a biopsy along with C5b through 9 and the immune globulin that we suspect is actually contributing to disease. So that sort of co-deposit would suggest that perhaps the antibody is activating complement, or that at least complement activity along with the antibody is actually triggering disease. And then finally, there has been some relatively recent data that C4D, that's on the classical side of the complement pathways. C4D breakdown products being deposited on the membranous biopsy may also signal to us that complement has been activated, and in fact, complement may be playing a role in disease. What about FSGS? Well, it doesn't get a lot better in terms of what the role of complement might be with FSGS right now, but I'll give you what I'm aware of at least. This is a relatively new study. 591 patients, 117 of them had a low C3. For their purposes, I think they called a low C was below 80 when they considered 92 or 93 was normal. So it wasn't like a rock bottom low C3, but it was a low C3. And what they discovered in that, they compared obviously all 117 and then all of the rest of their cohort. And what they discovered is that those with a low C3, it correlated with higher serum creatinine levels. It correlated with a lower GFR, correlated with a lower hemoglobin, and it seemed that those patients with the lower C3 had a statistically significant higher urine protein, higher lipid count, and increased tubular interstitial disease. So, and again, at this point, this is obviously just observational. They didn't do anything to perturb the system to sort of test it, but that's what they discovered in that cohort of patients, that in fact, in FSGS patients, it looks like having complement activity, whether you like their definition of low or not, or whether you even like the fact that they chose C3 as the complement biomarker that they looked at. It looked like complement activity was associated with a worse disease, if you will. Also, it turned out in that same study that a low C3 was correlated with a very high MAC in the periphery. So if we draw your blood and we do a C5b through 9 or a MAC, that the lower C3s would give you those patients had a higher MAC. And again, that makes sense if you think about the pathway again, that if your pathway is constantly going towards its end, then you are going to begin using up products that are more upstream, if you will. And that's a rather common finding for us in the kidney world, especially complement-mediated kidney diseases, in that if your MAC is very high, often your C3 is low because you're consuming it in order to make MAC. So that actually fits in terms of to suggest that maybe complement is playing a role. This study actually took it a little bit further. I should mention this one too. Actually, I'll just show you the graph. It was pretty impressive. The C3 level, again, we're talking about not a terribly low C3 level, but they actually made a correlation between the C3 level as an independent risk factor for the development of end-stage renal disease in these patients. And again, we can all recognize the problem with this kind of data, but what we're trying to do is sort of search for a reason, not so much to say that we understand complement is involved, but search for a reason to go looking, do better research to find out whether complement is involved in these diseases. This is actually from Josh Thurman from Colorado. He actually looked, this is back in 2015, he looked at 19 patients between the age of 10 and 37 who had nephrotic syndrome. That was their primary nephrotic syndrome. Most of these were FSGS patients, and their urine proteins ranged anywhere from 1 to 15. And I know these slides are busy, but I took it directly from his manuscript. And I just want to point out that this is plasma, this is urine, and I'll just tell you, this is BA, one of the breakdown products. This is BB, one of the breakdown products of B, so BA and BB. This is C4A, so breakdown on the classical pathway. And then this is C5B through 9, so that terminal pathway. And it's similar down here, BA, BB, C4A, and then the terminal pathway. And all I really want you to focus in on is you notice the spread for the FSGS patients. Many of the FSGS patients in his small cohort, granted, had very elevated complement proteins present. And so, again, circumstantial evidence that complement may be maybe not pathologic, but at least associated with the disease. Same thing with urine. There was actually increased in some patients, and it's hard to tell, but those with the empty box, those are the ones with the highest degree of urine protein, so the ones that are the most nephrotic, if you will. But the point is that, again, in that 19 patients with FSGS, there was some hint that there was increased complement activity. Another crazy slide. I'm not going to focus on anything except for right here, but the point is we have plasma, urine, the same thing again. This time we're comparing to urine protein, and we're comparing to the GFR. And I could have cut this in half for you, but the bottom line is that there's no correlation. So the point here, except for when you get here, and there looks like with BA, there is a correlation. And again, this is from the 2015 paper with BA, that looks like there is a correlation with you get more BA when you have a lower GFR. Similarly, there's actually some degree of correlation in the urine. If you have more excretion of BA in the urine, you probably have an increased urine protein. So what Josh wouldn't have known at this time, which I think that there's some decent data to suggest now, just getting renal failure, it really doesn't make any difference what your disease is. It doesn't have to be nephrotic syndrome. Will give you a problem with measuring your BA and your BB. Both of those components actually are abnormal, because it just turns out that the kidney is responsible for excreting that. So that ends up not being an important, those two boxes end up not being important for this particular purpose. And in fact, it doesn't actually support whether we have complement activity in FSGS or not. So I'm getting close to the end here, but what I wanted to just share with you in terms of right now, I took the liberty of taking the capital N and capital S off that and putting some quotation marks, because you probably know there are other diseases that have nephrotic syndrome, and in fact, it's really clear that complement plays a role in C3 glomerulopathy, so it's really clear that anti-complement therapeutics are going to be useful in that setting. It's also very clear in the setting of atypical HUS. If you know those two diseases, then you know that they're complement mediated. There's maybe some there's some decent genetic information that IgA nephropathy is probably has a complement component to it. But again, we're not in the mode of using anti-complement therapeutics for IgA at all. There's very little data for minimal change. Now, that doesn't mean that there won't be more data come for minimal change, but I think it's safe for us to say right now that we should not even if if it was $1 a dose, I think we probably shouldn't be thinking even about using anti-complement therapeutics in minimal change. I think where it gets a little fuzzier for me is that I think that membranous, I think that membrane attack complex on the podocyte actually could be an area for better research. We could figure out whether anti-complement therapeutics could actually help reduce the degree of urine protein in diseases like membranous. But we're not there yet. This is more a call to, we need more research than a call to actually begin using anti-complement therapeutics. I will say, if I go back to this setting, one of the things that we notice immediately by giving anti-complement therapeutics is the disappearance of the urine protein. So whether that would also be the case in membranous nephropathy is an interesting hypothesis, but again, we need a bit more science to support it. And then I would say there's even less information on FSGS to suggest that anti-complement therapeutics could play a role. But it's potentially ripe for some research. So 2 slides left for you, and you might say, well, okay, why are you even giving a talk if you haven't really given us much information about how complement's involved? And I guess the first point would be is that I do believe, at least in FSGS and membranous, it deserves more research, but this is maybe a scenario, and I never get this phrase right. Is it the dog wagging the tail or the tail wagging the dog, or however that goes? But to a degree, it's because anti-complement therapeutics are coming, and they actually are coming to just pretty much everywhere in the pathway. So if we were to discover that complement activity in any, or complement breakdown products in any one of these diseases actually becomes important to the pathology, then of course that increases your armamentarium of things that you should be thinking about studying in actual trials to see if they might work. And so I brought it back to this pathway because, again, you have C3, that C3A splits off, C3B enters the amplification loop, cleaves more C3, add another C3B, you get the C5 convertase, etc. You get all the way down to MAC. What I want to do is give you that same, and by the way, if you have the aflatoxin, of course you have cellular influx into wherever complement is being activated. So at the very least, stalling complement stalls inflammation. That's probably universal in the diseases, but what I've done is I've just sort of played with this figure and shown you wherever I've kept the dark print is where we have the capability to actually monitor the biomarkers on any of these. And that becomes important because as the anti-complement therapeutics become available to you, in fact, none of these are out. And if you actually Google clinicaltrials.gov, and I actually have the slide here for you, you can figure out what's coming and what's being tried. But this is a factor D inhibitor, so you can inhibit factor D. If you inhibit factor D, in fact, you do not get this cleavage. If you don't get this cleavage, you never get this entity. If you don't get this entity, you don't get this. So that would be one way to actually limit the production of a terminal complement pathway. We have a company called Novartis is bringing out a factor B drug inhibitor. Same story. If you can't cleave B to get to BB, you're not going to get downstream. There is a drug coming out called a C3 inhibitor, actually, which essentially binds C3b and limits this relationship. So again, you're limiting the ability to create this, and therefore you would limit downstream also. You all know Alexion's drug, eculizumab, because that's the one that's used on label for atypical HUS. In fact, Alexion's drug binds here, so that is a very expensive anti-inflammatory because what you get is no C5a. You also obviously don't get the terminal membrane attack complex. So again, if the data eventually supports that C5b through 9 does play a role, enough of a role in membranous that it should be adjunctive therapy, then that's something that you, some version of that could be considered. And then finally, I believe there is in trial now, I'll have to C5a receptor blocker, and that doesn't help you if, for instance, in membranous, it may not be useful if the membrane attack complex is the key component, but it might be, in fact, useful if it turns out that the real problem in any of the given nephrotic syndromes is actually the anaphylotoxin effect of C5a. That's the point there. And I just wanted to show you that we're kind of at the point where in a lot of different areas we're looking to see where complement, and I work in a complement lab, so of course we're looking to see where complement is active and what role it might be playing. But some of this actually might even end up being driven by if there are going to be, of course none of these are within any of our budget right now, of course, but if there are going to be inexpensive medications available to us and they can be adjunctive to actually help reduce the amount of urine protein and maybe reduce the nephrotic syndrome, it may be something worth thinking about. It's a very complicated pathway, but once you break it down into its individual parts, I always use the analogy, it's very similar to thinking about ACE inhibition. You know, you can use an ACE inhibitor, you can use an ARB, you can use a direct renin blocker. At some point, we'll be in the business of being able to choose a pharmaceutical that actually will block the complement pathway. This is my projection, of course. So, you know, there's lots of money and many years probably ahead of that, but we'll eventually be able to choose individual complement blockers based on where you think your individual pathology is. For instance, if you think the pathology is actually the terminal complement pathway, then maybe that's the drug for you. Or maybe someone will come up with one that, you know, binds C7, I don't know, something like that. But the future is here with respect to anti-complement therapeutics. We just have to figure out whether it actually is playing a role in our diseases, in our primary nephrotic syndromes. This is easily accessible to you. This isn't protected information at all. These are the complement targets. So if you can figure out where your disease is a problem, then in fact these drugs are going through trial now, and maybe they'll make it to your patient at some point. So what are our knowledge gaps? Well, the big one is, I said it from the very beginning, what exactly is the role of complement in the nephrotic syndrome? And is it just an epiphenomenon? In many places, it absolutely could be, like the example I gave you of minimal change. It just happens to be an association that there were elevated C3s in that group of patients, for instance. Or is it actually an agent of disease? That's one of the things we for sure need to figure out right now. And would anti-complement therapy, perhaps not right now when it's the most expensive drug in the world, but when a by-mouth form becomes available to you, when there's more competition, when the price is much better, when it's closer at least to a Rituxan price, for instance, maybe an anti-complement therapy may play a role. But again, as is always the case, we should push the science first to make sure that we understand if it even makes sense to be using things like that. And then finally, is it reasonable to do better than just saying the C3 is abnormal? Can we actually define in a large enough cohort where the complement pathway might be abnormal instead of just using the gross or the bigger markers? Well, it's just MAC or it's just C3. Is it even reasonable to think about being able to fine-tune that to a degree to see if it makes a difference, both in helping us understand pathology and in helping us understand what treatment options we need to think about? Here is our new hospital. We just moved into our clinics, actually, but I wanted to show you this because this is these are my medical colleagues who I absolutely love working with. We're a relatively big group, and we have lots of fun, and I really enjoy working with them. And then, of course, I have to show you my laboratory colleagues. This is the lab that I work in molecular otolaryngology and renal research laboratory, where we do lots and lots of complement work. Thank you, and I'll take questions.